Dear colleagues, dear ladies and gentlemen, welcome everyone to the first joint WHO EASL webinar on COVID-19 and the liver from the frontline. My name is Thomas Burke. I'm a hepatologist and head of the Division of Hepatology at the University of Leipzig, and I'm also Vice Secretary General of the EASL. Together with me is Philippa. We two together are chairing this webinar, and Philippa Easterbrook is an infectious disease specialist, an epidemiologist, and she's senior scientist in the Department of Global HIV, Epidemic, Hepatitis, STA programs at the WHO headquarters in Geneva. So welcome, Philippa. How are you today?
Thank you, Thomas, and welcome to you. Good afternoon to everyone. Thank you for joining this EASL WHO webinar and to EASL for the opportunity to contribute. Thank you.
You're welcome. It's a pleasure. So I think we have to run through the meeting objectives. Philippa, if you like to tell the people what our objectives are.
Thank you. Well, I think a key theme of this webinar is on maintaining continuity of services. So we're going to start with a brief overview of the key activities of the WHO in response to COVID-19. A further objective is to really understand the short and long-term consequences of the pandemic for patients with liver disease. Third, to understand the impact of COVID-19 on services and from the differing perspectives of the World Hepatitis Alliance, representing patient groups, frontline clinicians from across Europe, as well as from low and middle income countries, with additional representation from hepatitis program managers. So a real 360-degree perspective. We'll also learn about some of the strategies that are being used to minimize the impact of COVID on services and re-establishing services, and to highlight some of the interesting areas of innovation that may carry through to the new normal in the future. Thank you, Thomas. Over to you.
Yeah, thanks, Philippa. Yeah, so we have really and global attendance, and it would be very interesting to see what is the response from Europe and what is the response from low and middle income countries. So I would like to briefly run through the agenda. So we would like to start with a brief overview on the WHO response and updates to this pandemic. And then we're coming to the perspectives from the front line, first from Europe, where three experts from France, from Spain, and from Italy will show you how they deal with the crisis and the clinical management issues with COVID-19. Afterwards, we would like to introduce the EASL ASCMID position paper on the management of patients with chronic liver disease during the pandemic. And this is followed by our first clinical management issues and returning to normal Q&A session. The second part, and it's really split into both parts, approximately 40 minutes. We have the perspectives from the front line, from the low and middle income countries. And as I mentioned, we're really connected to the world with people coming from the World Hepatitis Alliance Global Survey, Egypt, Pakistan, and Malaysia. Welcome to everybody. And then the feedback of these countries on the hepatitis services in these countries and how the pandemic affects our mission to eliminate viral hepatitis. And then we have final closing remarks. So we have these two panel discussions, and please restrict your questions mainly to the different issues I've just mentioned. So the one from Europe with the issues returning to normal, and the second one of the hepatitis services in low and middle income countries. You may submit your question at any time throughout the webinar. Philippa and I, we can see it on our screen, and we will try to give a good mix of all the questions that are coming in order to address most of them. So By using the submission box, you can raise your question on the webinar page. Please enter your name, and it would be nice if you can say from where you're coming. And well, as I mentioned, please confine your question to the topics. And we are probably not able to answer all your questions, but the unanswered questions that will be put on our website, where you can find also the webinar on the EASL campus, and there we would like to try to answer most of them. The webinar will be available on demand on the EASL campus. And with this, I would like to hand over to Philippa to the WHO response and updates talk.
Thank you very much,
Philippa?
Thomas. Thank you. And first slide, please. And next slide, please. I shall begin with a recap of the timeline of the key events over the last almost 5 months, which should be well known to you all, starting with a report on the 31st of December last year to the WHO country office in China of a pneumonia of unknown cause detected in Wuhan, China. And this then led to immediate activation of the WHO IMS, or Incident Management System. On the 30th of January, WHO declared the outbreak as a public health emergency of international concern, and shortly afterwards launched the International Strategic Preparedness and Response Plan. And then on 11th of March, WHO declared Covid-19 as a pandemic. So the graph you see on the right shows the trajectory of the number of cases from January through May the 10th by WHO region. So you see here, just on the left part, the outbreak early on in China, captured in orange, and then the explosion of cases in the European region, shown here in red. And then subsequently the Americas, particularly the United States, shown in yellow. The Eastern Mediterranean region, which includes Egypt and Pakistan, who are represented at this webinar, shown in purple. And then the cases from the African region, you just see at the top bars in green. And you can see from this that we do start to see some signs of declining cases in Europe, but in other regions, right at the bottom of the graph, such as South Asia, the Caribbean, parts of South America, the numbers are still rising. Next slide. As of the 12th of May, we now have more than 4 million confirmed cases reported from 214 countries or territories and over 250,000 deaths. It's a sad milestone indeed. The map on the right shows cases in the last 24 hours with shading of the cases by country per million population. And there have been 85,000 new confirmed cases and 5,000 deaths in the last 24 hours. Next slide. So what is WHO doing? Well, what it's doing is what it always does in an epidemic response, which is namely to analyze data, provide advice, coordinate with partners, help countries prepare, and increase supplies through its expert networks. And I've highlighted on this slide some of the particular activities in the context of COVID, and we'll expand on these in some of the further slides. But essentially, core activities of scaling up country preparedness and response operations, the rapid assessment of evidence and generation of technical guidance with continuous updating, accelerating priority research and innovations, particularly relevant to candidate therapeutics, vaccines, and diagnostics, and rapidly establishing the international coordination through strategic and operational support. Next slide. On the COVID preparedness and response front, the strategy has recently been updated, and there are 5 key strategic objectives, which again should be well known to you: the mobilizing all sectors and government in preventing cases through the hand hygiene, as well as some of the individual level physical distances, controlling the sporadic cases and clusters, and preventing community transmission by the core activities of rapid case finding, testing, isolating, managing the cases and the contact tracing and quarantine, suppressing the community transmission through a range of measures, reducing mortality through appropriate clinical care, and the development of safe and effective vaccines. But what is key, and this is shown on the right, the intensity of these different actions will of course be based on the transmission scenario in each country, of which there are 4 main scenarios: no cases, sporadic cases, cluster of cases, and community transmission. Next slide. Well, since January, WHO's published an extensive range of COVID technical guidance. And as shown on the next 2 slides, in addition to the many scientific briefs and other tool calculators, together there's been more than 150 products which are on the website. And in all cases, the evidence base supporting these recommendations is kept constantly under review and the guidance updated. And I've highlighted just a few in red on the slide. So you will see the infection prevention and control, the issue of masks, which is under review, comprehensive clinical management guidelines, the laboratory, the testing strategies as use of immunodiagnostic tests, which is very topical, surveillance, and on to the next slide. Also covering the essential resource planning, the important maintaining essential health services, which I'll return to shortly, and some of the very useful calculators about planning health workforce, also issues on technical specifications for ventilators, and specific guidance for mass gatherings, as well as specific settings in the workplace, the vulnerable, prisons, and schools. Next slide. So I think I've just gone on to the wrong slide there. So I think there is yet still more guidance coming, but of particular relevance to viral hepatitis to highlight is the updating of the operational guidance for the continuity of essential health services. And we know that when health services are overwhelmed, both direct mortality from the outbreak and the indirect mortality from vaccine preventable and treatable conditions increases dramatically. And this has received a lot of attention recently with modeling work of the impact of COVID disruption to TB, malaria, and most recently HIV services. Next slide. So what do we know about the impact of COVID on hepatitis services? Well, most of our information is based on anecdotal reports, but also through our WHO colleagues in the 6 regional offices, our real eyes and ears for what is happening in the countries. And of course, the situation in countries is very much dependent on the degree of lockdown. And while hepatitis treatment interruptions have been reported, this is clearly much less of a problem and concern than the issue of continuity of ART, which really is a top priority in many countries. We've also had reported staff at MOH and hospitals being repurposed to support COVID, suspension of routine clinics, testing and prevention efforts affected, viral load testing affected because machines and personnel deployed for COVID, and specimen transportation. So in terms of the key messages on approach to mitigate, and this will be reflected in the updated guidance, imminent guidance on maintaining essential health services from WHO, that those with Hep B or C infection currently taking treatment should receive extended supplies, multi-month prescriptions to avoid missed doses. I think the other important group is harm reduction services for people who inject drugs should continue to receive access to needles and syringes, and opioid substitution therapy with extended supplies as required. Next slide. So very briefly on research, I think exponential increases are a hallmark of all pandemics, and the same applies to research papers on pandemics, with research papers on COVID doubling every 14 days. So more than 7,000 papers have been published in the last 4 months. And interestingly, around half of that scientific work has been released through preprint services. So this may be another one of the new normals emerging. I just wanted to make you aware, and this is at the bottom of the screen, of the WHO COVID database. It's updated daily from searches of bibliographic databases. but importantly, it represents the most comprehensive multilingual source of current literature on the topic. And I'm also just going to highlight two other aspects of research development in vaccines and therapeutics. Next slide, please. So, as you're aware, there are currently no licensed therapeutics for COVID-19. Many clinical trials are underway, but a key message from WHO is really the critical importance of evaluation of therapies based on randomized trials. So Solidarity is one such trial. It's an international trial launched by WHO and partners on the 18th of March. It compares 4 treatment options compared to standard of care. As listed below, there have been more than 1,600 patients enrolled from 11 countries, and results are expected in the coming months. A similar approach has been adopted for vaccines with the establishment of a broad coalition. You'll all be aware that many of the candidate vaccines are now passing through preclinical and into phase 1 and phase 2 studies. And a recent tools accelerator has been launched specifically to expedite progress with production at scale and ensuring equitable access. Next slide, please. I think because some of the chats that were coming in, I slipped in an extra slide on diagnostics, just to summarize that 3 molecular technologies have US FDA emergency authorization. 2 of these also have WHO pre-qualification. It's important that WHO is not recommending currently the use of antigen detecting rapid diagnostic tests for patient care, although research on their performance and diagnostic utility is really, it's of great interest. WHO is also not recommending the use of the antibody detection RDTs for patient care, but again, encouraging work to establish their usefulness in disease surveillance. Next slide. I think in addition to a diagnostics consortium that's been established to promote access, there is also a consortia for PPE and for clinical, particularly oxygen supplies, being coordinated by WHO together with the World Food Programme, specifically to identify the consolidated demand, coordinate the purchasing and streamlining the distribution, but this is still currently at the early stages. And my final slide, next slide, is to just make you aware of the many other resources that are available on the WHO website. I think this is useful. Some FAQs on Mythbusters. I think highlighting also the training opportunities, the Open WHO, which is an open access learning platform with 10 online courses related to COVID in 22 languages. And I would just like to finish by thanking the Health Emergencies Programme team at WHO, and also very much to my colleagues in the regional offices and the hepatitis focal points in the 6 regional offices. Thank you for this opportunity.
Well, Philippa, thank you so much. This is really a great start and really an excellent overview on where we stand. So I would like to continue in our webinar, and now we're coming from the perspectives from the front line from Europe. And it's really my pleasure to introduce our 3 experts, and we start with Professor Karine Lacombe. He's an infectious disease specialist at Sorbonne University in Paris. And I introduce all of them at the same time. So this will be followed by Professor Javier Fernandez from Barcelona. He's hepatologist, but also the head of the liver ICU in the medical center in Barcelona, and Professor Mario Mondelli. He's both an ESCMID and an EASL member. He is an infectious disease specialist and hepatologist in the University of Pavia. So please, Karine.
Okay, thank you very much, Thomas, for this nice introduction. So I would like to share with you some perspectives about the front line in France. And first of all, to give you an overview of the situation about COVID-19 in France from the 5th of May to 2020. So you see here 3 graphs. So the first one is the number of new daily ICU admissions and deaths. And you can see that over the weeks, it has been going down and down, fortunately. And the number of patients presently in ICU is also going down, but you see that it's at a much lower rate than the number of new admissions and deaths, which means that the patients who are entering ICU stay there for weeks and weeks, and about 3 to 4 weeks, and a lot of them go out of the ICU with sequelae. So we are right now facing the acute phase of the epidemic, but I'm pretty sure that we're going to face now like a kind of chronic state for the epidemic regarding the health of the patients. And I wanted to focus specifically on the number of healthcare professionals getting infected. And you see here on the graph of the right of the slide that I have reported the number of healthcare professionals infected related to the admissions for COVID-19. And you know that it has been said in many places that healthcare professionals were very much exposed to infection through patients hospitalized. But you see here that there is a perfect symmetry between the HCP infected and number of admissions in my hospital, which means that the healthcare professionals who are getting infected not from the contact with patients, otherwise there will be a difference of 2 weeks between the admission and healthcare professionals. And you see that it's exactly the same, which means that most of the healthcare professionals got infected outside of the hospital or inside of the hospital, but when they were together and not not specifically in contact with the other infected patients. Next slide, please. And I also wanted to show you what I think is a good picture of the intensity of the epidemic throughout Europe. And this is the excess in mortality by the end of April in many countries. And I let you look at this slide and make your own judgment. And you see that in some countries where there was no confinement, the number of deaths were quite high. And I invite you to go on this website, euromomo.eu, if you want to have very accurate data regarding excess in mortality. And it's updated every week. Next slide. So now I would like to focus on 4 challenges that I have identified that I would like to share with you. So the first challenge that we've been facing especially in March and April, where how we could identify the patients who may rapidly deteriorate upon arrival in the emergency room. And we all know about the risk factors for severe cases of COVID-19. And in March 2020, our Haut Conseil de Santé Publique have published a few risk factors identified, and you probably share the same factors in your country. But however, beside those factors, we saw that some patients could arrive on room air in the morning and get intubated in late afternoon. And it was not only related to that kind of risk factors, and it's still quite a mystery. And you know all about this concept of cytokinic storm. And we are still investigating, you know, the physiopathology pathways behind this cytokinic storm. And this is a very unique disease that can trigger this very rapid evolution throughout the day. So next slide. The second challenge I wanted to share with you was the neuropsychological injury associated with COVID-19. And it has come from observations of many patients who came to hospital in a very severe state of respiratory needs, and we were quite puzzled because usually, you know, when you are gasping, when you need some oxygen, you feel very anxious and you seek care very quickly. But in fact, we had many proofs of patients who came in a very late stage. It was like they had a decreased awareness of severity of respiratory deterioration. And for example, this 52-year-old male was washing himself at a basin without oxygen, although we had just come in his room and get out of the room to call for the intensive care specialist for an advice after rapid respiratory deterioration. And this patient had a polypnea of 35 per minute with need of oxygen at 12 liters to maintain oxygen saturation above 92%. And we went out of the room just to call, and then, you know, when we came back, he had no oxygen and he was just washing himself. That was completely, you know, completely unadapted to the situation. Second very important thing was a poor identification of dyspnea or hypoxemia signals and a kind of emotional blunting. And for example, the 61-year-old male who was on the verge of getting intubated, he just asked the nurse to call the doctor so she could not forget to call the mechanic for his car. So you think was completely, here again, inadapted. And after discharge, we noted a lot of mood instability with episodes of great emotional distress and irritability. And it looked like it was a post-traumatic stress disorder. And that's why I wanted to highlight this challenge of neuropsychological injury due probably to the virus on the brain. Third challenge, next slide, please. That's how we could do without known efficient therapy. And just to remind you that we've been investigating the repositioning of some drugs, and new molecules are being developed, and probably vaccine in the near future. You all heard about the controversies around hydroxychloroquine and remdesivir, and all other data from efficacy of immunomodulatory drug derived from non-randomized trials or observational cohorts, and a lot of those drugs had drug-drug interactions with hepatitis drug, for example, or immunosuppressive drugs in the context of liver transplantation. And that's why every day in my hospital, we had multidisciplinary meetings with internal medicine, infectious disease, and ICU specialists, along with pharmacists, clinical research staff, to identify the best therapeutic strategy in the light of no known efficient therapy. And that's how we managed to include patients in clinical trials, so to offer the best therapy to the patients who could not be included in clinical trials. And finally, the last challenge, next slide, please. The challenge number 4 was to maintain the sexually transmitted infection screening, including acute hepatitis C infection and HCC screening in the context of a no COVID-oriented hospital activity. Because all my hospital turned towards the response to COVID-19, and we had almost no bed left without COVID at some point, late March and beginning of April. So the situation was that STI clinics had stopped their activities in mid-March, and the daycare hospital where we would take the patients for HCC screening, for example, were maintained only for emergency. And myself, I decided to maintain daycare hospitals for screening for HCC. And the issues behind that we could face a delayed diagnosis of HCC in hepatitis infected individuals. And I have to acknowledge the fact that thanks for that kind of management, we were able to diagnose too early HCC in patients who would otherwise would have a delayed diagnosis of HCC if we had postponed the follow-up until, for example, September. And we also diagnosed some acute Hep C infection in at-risk individuals like MSM and people who were using drugs, thanks to maintaining a basic access to services for screening. And that's my last slide, I think. I'd like to thank you for your attention, and I will answer to questions a little bit earlier after my two colleagues.
Okay, thanks a lot, Karin. And now we move forward to the presentation from Spain. Professor Fernandez.
Hello, everybody. I will try to show you which was the situation that we faced in the last 2 months in Spain. And this slide shows you the trends of COVID-19 infections in Spain in these 2 months. In the graph on the left, you can see the total number of cases by severity that we had in Spain. in blue, a huge increase in the total number of cases, over 6,000 around in the middle of March. In green, you can see the number of hospitalizations that reach 4,000 a little bit later, and also a parallel increase in the admission in the ICU, and also in the number of patients dying. In the graph on the right, you can see the variation in positive cases in percentage. You can see that we had the higher increase in percentage, over 40% at the middle of March, and that little by little we had a decrease in this percentage of positive cases, and that now we are around 1 to 2% of increase in positive cases. Next slide, please. You can see in the map on the left that this COVID-19 infection affected all the regions in Spain, but that this was an affectation, but it was irregular. There were regions with a great prevalence of infection, especially Madrid and Barcelona, with the highest numbers. You can see more than 70,000 patients affected in Madrid, and more than 55,000 in Barcelona. These are data from yesterday. We have 271,000 patients with COVID-19 infections, and around 10% of them died in our country. Unfortunately, the majority of them recovered, 140,000 patients. Next slide, please. This slide shows you a very interesting, the preliminary results of a very interesting study that were published yesterday, where we had access to this data. This is the prevalence of antibodies for SARS-CoV-2 infections in Spain. The study evaluated more than 30,000 subjects, and you can see that the prevalence of antibodies is not very high, it's around 5%, and that there are marked differences depending on the region. There are regions around Madrid with a prevalence of around 10–15%, other regions in light blue that reach 7–8%, and there are also regions in Spain in white with a very low prevalence, zero prevalence of antibodies. Next slide, please. Well, how we manage this challenge? Obviously, this huge increase in the number of patients coming with this very severe infection supposed the lockdown of all the services, or the majority of these services, except for emergencies. And in fact, we dedicated almost 90% of the hospital to these COVID-19 patients. This supposed a huge increase in the number of ICU beds. We doubled the numbers, and we expanded the hospital to other buildings, such as hotels, and we tried also to manage the severe patients in the home hospitals. We also had to recruit a relevant number of physicians and of students to attend this crisis. And we also faced a huge increase in the needs for supplies of material for intensive care, high-flow nasal cannulas, ventilators, video laryngoscopes that are recommended for intubation of these very infected patients. And also, we also had problems to have the adequate supply of protective equipment. We try to maintain our contact with our patients with the telemedicine assistance and minimize the clinic outpatient. And also we need to increase the pharmacy supplies, and we were quite close to stop break, inhalation, antiviral therapy, and relaxants. I would like to underline that at least in our hospital, in hospital clinic in Barcelona, we were capable to maintain an epidemiological surveillance program in physicians attending these COVID-19 patients, these first-line teams, by performing weekly nasopharyngeal smears. And this allows us to detect these asymptomatic carriers and to avoid the spread of the infection among healthcare physicians. And we observe also that in spite of having a part of the hospital working in a very, very intense manner, doubling of or in 300% manner, the clinical activity of the non-COVID physicians, or the non-COVID part of the hospital, radiology, hematologists, pathologists, was quite low. So we face relevant difficulties in the management of our COVID-19 patients because of the lack of resources coming from other specialists. Next slide, please. And this is my last slide for the moment. This slide shows you the total number of patients admitted to the hospital clinic in Barcelona during the pandemic. Around 2,400 patients admitted for these infections, more than 250 required ICU admission, and around 180 intermediate care, and the rest were attended in regular ward or in hotels or home hospitals. We had a relatively low mortality rate, 8%, and the length of hospital stay was around 13 days. And the graphs on the right shows you the prevalence of COVID-19 admissions, showing all beds or in the intermediate care or ICU beds. And you can see we face a huge increase in the number of beds dedicated to these patients around at the end of March and at the beginning of April, and this has decreased a lot in the last weeks. I think this is my last slide for the moment. Thank you to the EASL for the kind invitation to participate in this webinar. Thank you.
Yeah, Javier, thanks a lot. I think we just move forward. Mario, Professor Mondelli, please.
Hello. Hello, Thomas. Thank you very much. I would like to talk about the Italian situation. And I'm very interested, actually, Javier, to know the situation in Menorca, because I own a house there and I want to be safe this summer, if I ever had the chance to spend a couple of weeks there. I mean, the situation in Italy, you can see on the left panel, hit badly the north of the country, and particularly Lombardy, where Milan is situated. This is where it all started, although epidemiologists say that the epidemics in Europe probably started in Germany. But anyway, there was a small town, a community hospital in a small town southeast of Milan, where a lot of patients attended and were admitted to hospital with a pneumonia that was later identified as COVID-19 related. Now, luckily, the south of the country, as you can see, was spared, particularly Sicily, Calabria, Sardinia. You can see, fortunately, the hospital structures were not badly hit, and actually the community medicine there did a wonderful job to stop the spread of the epidemics. So the total number of cases now, as of yesterday, was over 220,000, and currently positive patients over 80,000. But still, we have the recovered patients overtaking the positive cases, and sadly, we have a large number of patients who sadly succumbed because of the infection. Next slide, please. You can see the left panel, the national trends of the infection. The currently positive cases dropping slowly after reaching a plateau since the month of April, where it reached the peak infection. and the green line showing the recovered, the number of recovered cases overtaking those of currently positive, and the seized patients will hopefully reaching the plateau. On the right panel, you can see that the new infections dropping slowly, but definitely and convincingly. But we all very concerned about a possible second wave hitting the country either before the summer or right after the summer, after the government lifted the lockdown, or partially lifted the lockdown last week, and probably will lift the lockdown almost completely by June the 1st. Although theaters and cinemas, discotheques, and all the crowded places will be locked for a longer time. Next slide, please. The next slide, please. Now, the key issues and the challenges we faced very similar to those illustrated by Javier. All the services were locked down. We were compelled to admit only patients with COVID-19, except emergencies. But in the region of Lombardy, we have a network, a hub network of activities, and Pavia maintained the stroke and STEMI activities, hub activities, but all the rest was completely locked down to allow for the admission of patients with COVID-19. So the hospital had to be completely reorganized by increasing significantly the number of beds in the ICU, and we had also transformed part of the ID wards, infectious diseases wards, into sub-intensive wards, or even ICU, resident ICU wards in the ID departments. We also had a resident intensivist, and you can imagine the supplies. We had an enormous increase in oxygen consumption, as I would expect. We had some crisis at some stage on the supplies of personal protective equipment, and some concerns about the supply of ventilators, but we managed to do all of that, and the flexibility of the hospital managed to comply with the changes. We built almost overnight an emergency unit in the infectious disease department, but certainly very soon the overflow of patients had to be transferred to pneumology and to general internal medicine, to which almost 400 patients admitted at any one time. All these required a strengthening the hospital staff, so we appointed a new specialist in infectious diseases, intensivists, and pneumology trainees, and a lot of nurses being transferred from the south, where the situation was more calm. And there was a total lockdown of the outpatient clinics while ensuring essential care for patients with chronic hepatitis and HIV. All the hospital pharmacy supplies were maintained, but telemedicine assistance was implemented. And the next slide, please. This shows a floor of the infectious disease building, which was totally changed as a result of the COVID-19 epidemic. In green, it's shown the regular rooms, isolation rooms for the patients, whereas in red, where there was an ordinary ward with different rooms, 2 bedrooms, was completely changed into an open sub-intensive ward, later converted into an effective ICU division per floor to allow for overflow from the ICU, regular ICU units. Next slide, please. And this is my last slide, just showing how COVID-19 impacted on liver services in Italy. And this is a survey which was recently launched by the Italian Association for the Study of the Liver. You can see on the top the number of beds that had to be reduced or converted completely for COVID-19 care, reaching almost 60% of the GI or infectious diseases wards that were predominantly dedicated to liver patients. Liver transplant programs being either reduced or totally canceled, about a third of them, and the care pertaining to hepatocellular carcinoma surveillance or local regional care or surgery being heavily reduced, and also all the outpatients activity pertaining to chronic liver disease, compensated cirrhosis, and decompensated cirrhosis being partially or completely blocked in several hospitals. And I want to mention that endoscopy suffered quite a bit, and all the maneuvers related to endoscopy had to be cancelled because of the high risk of transmission of COVID-19 to the medical and paramedical personnel. And I have to say that the doctors and nurses pay a very high toll in Italy, with over 210 patients, doctors and nurses deceased over the epidemic so far. So this was my last slide, and I'll be happy to reply to questions later on.
So thank you very much, Mario. Thanks all of you. And we are now moving forward to the introduction of the EASL ESCMID position paper. So if you can show the next slide, please. And the next one, please. So given the current pandemic, in March, the European Association for the Study of the Liver Disease, EASL, and the European Society of Clinical Microbiology and Infectious Diseases, ESCMID, have issued a position paper providing recommendations for clinicians caring for patients with liver disease. So the next one, please. So this was a situation where, because of the current pandemic, it requires unusual allocation of healthcare resources, which may negatively impact the care of patients with chronic liver disease that continue to require medical attention. So for the first time, I think, in our lives, we were really challenged and faced to promote new forms of outpatient and inpatient care by using telemedicine. We have to do a kind of a triage to prioritize outpatient contacts. And this was all also due to the social distancing policies and to avoid nosocomial dissemination of the virus to patient and healthcare providers. But at the same time, and this was part of the intention of this paper, we need to maintain standard of care for patients who required immediate medical attention. So care of patients with liver disease under the pandemic, I think, and this is written in this paper, is a balancing act. And it depends on the national, local infection dynamics, whether it's exponentially increasing, declining, what are the national restriction containment policies. On the local situation at your medical center, of course, and there are quite different hospital-based restrictions, and whether the situation in your hospital is stable, whether it's heavily hit by the pandemic or not. And most importantly, and this is really what we would like to discuss here, the severity and the stage of the liver disease, and of course, whether you have a stable or an unstable disease, you're a transplant patient, HCC, or decompensated cirrhosis. So what we tried to help and to recommend is that according to the situation, oh, sorry, we need the next slide, please. The next one. Sorry, I haven't said it to you. The next, please. So what we really tried to do is to differentiate whether the patients are stable. And here, of course, the visit to specialized centers can be postponed. Also, routine laboratory testing can be done locally with the family doctors you have to involve. And you can use telemedicine visits by phone wherever possible. But I think it's very important that the patients know that you're taking care of them even remotely and that they have a clear management plan when it goes back to normal. And on the other hand, we have the patients with decompensated liver disease, liver transplant, and patients with hepatocellular carcinoma, where there was a clear recommendation that care should be maintained according to current guidelines, and you should also continue systemic treatments and evaluation for liver transplantation for patients with hepatocellular carcinoma. But there is a bit, this next slide, this balancing act, because at the same time, we are recommending, if you are really on the peak of the pandemic, wherever possible, avoid admission in order to reduce the risk of nosocomial transmission. So the next one. There are also some unanswered questions, and there are many of them related what COVID really does on the liver and how is the interaction between these and how probably immunosuppression for patients after transplant, autoimmune diseases will influence the course of COVID-19. What about the cirrhosis-associated immune dysfunction? Will it affect the emergence of protective immunity once you were infected? What about innate and adaptive immune activation or exhaustion in COVID-19 and their impact on chronic liver disease? And this is still an unanswered question. And a special concern is that in a patient with a compensated liver disease, a COVID may lead to a decompensation and the most severe form, acute and chronic liver failure. The next one, please. So we do hope that we can answer some of these questions by large registries that are out specifically addressing patients with liver disease, and data can be entered. And there's one, and there are two, let's say, working together. The one covering mostly European countries. This is the EASL COVID HEP registry, liaising with the US-based Secure Cirrhosis registry. Also, many Asian countries are involved. And you see already more than 490 patients with chronic liver disease were entered. 209 of them with liver cirrhosis. And if you can go please to the next slide. You see here that we already have death rates in these patients. Of course, it's selected patients, in-hospital patients entered into this register. But here it really seems that having a cirrhosis could make a difference with a much higher death rate as compared to those with chronic liver disease. And the patients after liver transplantations are in between. So next one, please. So it's really a concern and the challenge of maintaining standard of care for patients who required immediate medical attention, and also to deal with all the restrictions and avoiding admissions and nosocomial transmission. But this really has created a situation where many patients are now afraid entering hospitals. And this can lead to dramatic situation, and you can see in the next slide. And this is cardiology experience and data coming here from Italy. And Mario probably would like to explain these data, what happened with out-of-hospital cardiac arrest patients.
Yeah. Thomas, this is really a tragedy because it shows that there is an overwhelming excess of out-of-hospital cardiac arrest compared to last year in the very first months of 2020. And this is, we actually had the opportunity to discuss this point at the usual meeting we have every day on different aspects of COVID-19. This is really due to the, as you correctly said, to the fear of the patient patients to access hospital structures because of the COVID-19 epidemics that actually started in Italy exactly in a small community hospital where a lot of patients were exposed to the index patient and the doctors that got infected because of that. And actually, out-of-hospital cardiac arrest was due to a number of severe transmural myocardial infarction with rupture of the heart. So things that under normal condition you would see very seldom. And although we are a hub for ST for myocardial infarction, we saw these cases being transferred too late to the emergency department. So that's one point. And that brings me to the last slide. I think I would like to, it's up to you to comment on this, Thomas.
Yeah, thank you, Mario. And I think we have not as well documented data, but similar feelings that the admissions because of heart attacks also in Berlin, other cities in Germany are lower than it were before. And the expectations for patients with liver disease or the consequences might be quite similar. And according to this nice review, you see we are now in the first wave where we do postpone admissions and we are taking less care of patients with liver disease. And this most likely will lead to a second wave. And some colleagues already told me that they do see patients in more advanced stage of their liver disease. We have the wait list drop out from the waiting list for transplant, and we have a huge backlog of deferred visits and tests. And this in the long run may lead to a third wave where we have misdiagnosis due to lack of screening, and this ultimately may really lead in a higher liver-related morbidity and mortality. And this is really something we are very much aware and concerned of. So I think to start the discussion, I think Mario and Javier, you have some thoughts on how we can come back to normality. In the interest of time, could you be quite short explaining what you're doing in your countries, and then we come up to the open discussion. So Mario, please, your first slide.
Thank you, Thomas. Well, the last thing we want is to transform COVID-19 into a hospital infection. So first of all, how can we use virological tests to lift lockdowns to ensure at the same time safe access to hospital by the lay people? So what do we know about serology versus molecular testing? Or as Philippa mentioned, the detection of antigen in saliva. This could be all tests that should be done and to provide a very quick result in order to very early and simultaneously have the means to either isolate the patient or to provide cohorting between patients who are positive for COVID-19 or compared to those that are negative. So there should be an access whereby the patients with access to the hospital in complete isolation and have a quick test, quick but precise test to determine whether you should be isolated or not. Getting back to hospital normality will not be easy because if you imagine the very crowded waiting rooms or the outpatient clinics, the patients should be divided into blocks of a very limited number of patients. Social distancing should be ensured in the waiting rooms, and the patients should also be screened for the positivity, swab positivity or anti-serological positivity. We should go back to a correct surveillance of hepatocellular carcinoma, doing imaging screening with all the ultrasound and second level examinations. Ensure endoscopy and treatment of decompensated liver disease, and provide elective surgery and local regional intervention to those patients with cancer who are in need of those treatments. So I think this is the most challenging aspect of COVID-19 pandemics, to restore normality in hospitals. I don't believe we have for a long time we'll have a normality at all, but we have to adjust. We cannot have COVID hospitals and normal hospital. We have to be prepared to avoid that COVID-19 will be a hospital disease, nosocomial infection.
Yeah. So thanks a lot. A very important message. And Javier, a very brief statement from your side.
For sure. In order to restore our normality and to maintain the safety of our healthcare physicians, we should try to detect all potential COVID-19 patients that are asymptomatic. And in this way, I think that the strategy proposed by the World Health Association, this test should be performed. What we are proposing now is that at least for patients submitted from other hospitals and for patients that are scheduled for surgery or endoscopy, these patients should be screened for SARS-CoV-2 infection. And if the results are negative, we should proceed with the surgery or with the endoscopy. Next slide, please. And I will show you in the next two slides. Next slide, please. The proposal that has been designed by our infectious disease specialists and about where to admit a patient that requires hospital admission. This is just a proposal, it's not evidence-based. What we are doing now is that for patients with no prior COVID infection, and if the patient has symptoms of normal check-X-ray, we admit the patient to a COVID ward. And in the absence of these symptoms or with a normal check-X-ray, we perform a PCR for detecting this infection. If it's positive, the patient is admitted to the COVID ward, and if not, to the regular ward. In the presence of a patient with a prior COVID-19 infection, we look at the past history of this infection. If the infection was more than 8 weeks ago, the patient is admitted to a regular ward. And for patients with a shorter period, less than 6 weeks, we perform a PCR again, and if positive, the patient is admitted to the COVID ward. And in the middle, for patients with symptoms that came from 6 to 8 weeks, we look at other data, the age of the patient, immunosuppression, or requirements of ICU admission in the prior COVID infection. And if the answer is yes for these patients, we perform the PCR, and if not, we admit the patient to the regular ward. In any case, patients admitted to the non-COVID ward are submitted to dropout isolation measures in order to avoid potential transmission of underdiagnosed infections. Next slide, please. And regarding the outpatient clinic, what we are doing nowadays is to perform a call phone before the outpatient clinic to perform a medical evaluation to ask for symptoms or respiratory symptoms or fever. And if the answer is no, there is no symptoms, there is no suspicion of infection, we look for a prior history of COVID-19 infection. If there is no history, we can visit the patient. And if there is a prior infection, it's again evaluated the time of this infection, and we apply more or less the same scheme that I have explained in the past slide. In the setting of a positive PCR, we try to postpone the visit for the patient, or we schedule a visit in a COVID area. And this is my last slide. Thank you so much.
Okay. Thank you very much to all of you. I think these were very important information. It's really interesting to see and to learn how the different response in the different European countries are. We are bit overrunning with our presentations and part, and to have enough time for the second part, I would like to restrict it now, the Q&A session, to mainly 2 topics and 2 questions. And the one is probably one for Karin, and there are a number of questions around hepatitis B and whether hepatitis B is a specific risk factor and how to manage these patients. Can you continue with treatment? Can you start treatment? So what is the answer to this?
Well, as long as there is no immunosuppression in the liver, for example, definitely cirrhosis. So when the patient is not at a cirrhotic state, is not at a higher risk of severe SARS-CoV-2 infection, and there is no known DDI, drug-drug interactions between hepatitis drugs and the drug that might use to treat COVID-19. So I think that so far there is no known risk of a higher, of a more severe evolution of the disease.
Okay, thanks, Karin, a lot. And the second question, probably for you, Mario, is all around, is the SARS-CoV infection affecting the liver? So we know that 20 to 40, 50% have elevated ALT levels. Is there any specific histological feature? And what is the current knowledge?
But unfortunately, the number of autopsies is not very high. We have data from Bergamo, which is about 50 kilometers from Milan, where there's a big hospital and a big pathology service. They started doing autopsies, and they perform more autopsies than in China, for example. And the liver, it's really part, I mean, the lesions are really part of a multi-organ failure. There is no specific morphological picture that can be referred to COVID-19 infection. Certainly, all the patients develop some sort of ALT elevations, predominantly the ALT and AST, but no cholestasis. For example, although we did detect one patient with increased cholestatic enzyme, but there is still a lot of to do to understand what is the impact of SARS-CoV-2 on the liver. Although we know, for example, the receptors are also expressed on hepatocytes, as in many, the ACE2 receptors are expressed ubiquitously, and the liver is just part of the complex systemic syndrome caused by COVID-19.
Mario, thank you very much. You know, there are several other questions around the risk of patients with cirrhosis, some of them developing liver failure, and the role of NAFLD and obesity. And we would like to try to answer these questions afterwards, and you can find the responses and the reply on the website. So it's my great pleasure, Philippa, to hand over to you to the second part.
Thank you very much. So we're going to move swiftly on. I think along the same theme of returning to normal, and hopefully we can return to normal time, but we are 20 minutes over. So we've got a great lineup for this next session on the impact of COVID on hepatitis services in low and middle income countries, which will start with a presentation from the World Hepatitis Alliance and their global survey, followed by presentations from Egypt, Pakistan, and Malaysia on how they've adjusted to the COVID pandemic. So I'd like to introduce the first speaker, Kerry James, who's the CEO of the World Hepatitis Alliance, which is an organization representing almost 300 patient organizations in 95 countries, who present on their key messages from their global survey, and just to ask all the speakers to be as brief as possible. Thank you. Over to you, Kerry.
Hi, thanks, Philippa, and thanks to WHO and EASL for inviting us to participate in this important seminar. So next slide, please. So I'm going to talk about a community-based research survey that we started a few weeks ago. And the objective of the survey was really to kind of measure the COVID response, to measure the effect of the crisis on civil society organizations, and on their ability to deliver services, to measure the impact of the crisis on viral hepatitis patients and their ability to access treatment and services, to measure the impact of various factors related to COVID, including like stay-at-home orders or anxiety around accessing healthcare facilities. And finally, we just wanted to do the survey to gather examples of best practice for dissemination within our 300 members around the world and to inform our work during this time. Next slide, please. So the format of the survey was a self-completion online questionnaire with 13 questions, multiple choice, and also free text questions. And the survey was promoted through our members and also through various hepatitis sector stakeholders, through social media and through some of their networks. And up until yesterday, we had 128 responses from 32 countries, which we're really encouraged by. Because of the way that it was disseminated by some stakeholders, we did have a particularly large sample from the United States with 62 respondents. So in the data that I'm going to be showing you in the next slides, unless indicated, we've actually taken the sample from the United States out, so it wouldn't skew the results too much. But when we do the final analysis and present this data again, we will take that into consideration. But otherwise, you can see the countries are really spread around the world, spread in terms of economic level and geography. So we were really pleased. Next slide, please. So one of the key questions, of course, were, are people with viral hepatitis able to access treatment at this time? And you can see that while most people responded that they were, a worrying minority, over 30% said that patients weren't able to access treatment, which of course is a huge cause for concern. And when we kind of looked at individual countries, so the table on your right, so these are the 4 countries that we had the biggest sample sizes, and they also represent different geographical locations and different socioeconomic situations. And as you can see, in India and Nigeria, they were definitely reporting more trouble with patients accessing treatment, while in the United Kingdom, where we have universal health coverage, we have a national health system which is free at the point of care, there was no reports of difficulty accessing treatment. But in the United States, where there's more of a mixed system, where there were reports that people were having difficulty accessing treatment during this time. Next slide, please. And the reasons for this, the most popular reason, or the most common reason that was reported was travel restrictions. But second, and this kind of came up in the previous discussion, was that people were avoiding health facilities because of their fear of COVID-19. So this is obviously a trend that's kind of going across several different areas. But also, they also reported that many health services were refocused for COVID-19, so their hepatitis services or the clinics had closed, or just that generally that the health facilities were closed. So there's a really kind of mixed picture there, but a lot of people weren't accessing out of fear rather than with a service not being available. Next slide, please. And so, of course, we're concerned about whether there's adequate information for people living with viral hepatitis about COVID-19, its effects, whether they're more at risk, because definitely we heard from our members that this was an issue in many countries. And indeed, when the results of the survey show that almost 2/3 said that they felt there was not adequate information or they were unsure. So we wanted, as WHA, we wanted to respond to this. So we created an online information hub with all of the current information collated on COVID-19 and viral hepatitis. And you can find that on our website at worldhepatitis.org/COVID-19. Next slide, please. So we also wanted to talk about the services provided. And the majority of the sample was civil society organizations, but also healthcare facilities also responded to the survey. Ministries of health also responded to the survey. And as you can see, actually the legend on the side of the table on your left is wrong. It was actually 90% of the respondents said that that their services had been interrupted or affected by the COVID crisis. And here, as you can see on the right, we had a free text box where people could talk about why they thought this was the case. So after that was coded, the most common reason for people not accessing their services was this fear of COVID and the fear of accessing health facilities, and that was more than any other reason, including the facilities being closed. So obviously, the fear of COVID is as big of a barrier or a bigger barrier than the actual practical things or the restrictions placed on people for movement. Next slide, please. And just to wrap up, this will be my last slide. So as I said, we haven't really had an opportunity to analyze the data properly and all the free text responses, but I think it's just an overview. I mean, it's quite obvious from this that the COVID crisis has impacted the ability of most civil society organizations to deliver services, screening services and services. The COVID-19 crisis has impacted patients' ability to access viral hepatitis treatment, and this seems to be more prevalent in low and middle income countries. The reluctance of people to access health-related services at this time can be an even greater barrier than limitations on movement or the closure of services. And most respondents did not agree that adequate information about COVID-19 and viral hepatitis was available for their countries. So I'm going to leave it there. I'm going to say thank you to the organizers, and thank you very much for listening.
Thank you so much, Kerry. Some very interesting preliminary results. We're now going to move swiftly on to the presentation from Egypt, and I'm pleased to welcome the presenters, both Mohammed Hassani and Manal Al-Sayed. So Mohammed Hassani is a hepatologist at the National Hepatology and Tropical Medicine Research Institute in Cairo and executive director of the National Committee for Control of Viral Hepatitis. Manal is a professor of pediatrics, director of the Clinical Research Center at Al Shams, and a founding member of the National Committee. So over to you both for a presentation. Thank you.
Thank you very much, Philippa. Next slide, please. As a part of the global efforts to face the pandemic of COVID-19, Egypt is trying to manipulate its healthcare system capacity in a balanced way to maintain the daily health services since the discovery of the first case on 13th of February 2020. Starting from the 24/7 operating command and control center with a capacity of about 200 agents and 20 well-trained medical staff receiving more than 10,000 phone calls and requests per day asking for either awareness, symptoms verification, and directing the suspected cases to the triage hospitals, receiving the positive cases notifications and their clinical assessment, choosing the proper isolation hospital, and sending the requests to the ambulance agency. All the suspected cases were referred to what's called triage hospitals. These are 58 fever and chest hospitals in Egypt with more than 10,000 healthcare workers, and bed capacity reaches to more than 2,000 beds. These hospitals are responsible for the initial clinical assessment, PCR testing, and temporary admission and isolation for indicated cases. Now we have about 34 labs providing the testing capacity of nearly from 20 to 30,000 tests per day, and also a dedicated ambulance fleet containing about 1,500 vehicles and 2 air ambulances with more than 4,000 ambulance staff and 1,200 logistic staff. To avoid any collapse in hospital capacities, Egypt endorsed the model of admission of the mild cases to hotels, dorms, and hostels, and also to leave a proper space inside the hospitals for more advanced cases. Till today, we have about 19 hospitals with 2,600 bed capacity and about 500 ICU beds with ventilator supported beds. Also 24 hostels and hotels and dorms with more than 4,000 bed capacity. In that model, we have more than 4,000 healthcare workers who are in the front line of cases management. And finally, a huge team includes about 18,000 healthcare workers responsible for isolation and contact tracing for more than 1 million close and significantly casual contacts, and also the quarantined expatriates. Next slide, please. Looking into the current situation, now among about 163,000 examined samples, we have 9,400 positive cases. 2.9 of cases are severe and critical. The mortality reached to about 5.5%. Until now, we have about 22% of cases are cured and discharged. And now I hand over to Dr. Manal to continue the presentation. Thank you.
Thank you very much, Dr. Hassani. May I have the next slide, please? Well, just a brief overview on our program that started in 2006 for elimination of viral hepatitis, where we established liver centers, a networking system with a database, and treated 350,000 with pegylated interferon and ribavirin until the new brand direct-acting antivirals were introduced in 2014. We had also a national registration system for people to register to receive treatment. It is known to be the largest program in the world and has been and made the headlines in the New York Times. And then by 2016, we introduced generic medications and we managed to treat over 2 million patients. In the meantime, we had another survey for hepatitis C, and we learned that we have at least 5.5 million people who are still infected with hepatitis, and we've treated 2 million, so we had to look for the other 3.5 million. And as the program was losing momentum and we were running down of registrations, we started a national screening program targeting all adults in the population and eventually also children and adolescents above the age of 12 years. And during a period of 7 to 10 months, we managed to screen, including children, almost 59 million of the population. We had a school children program as well. Of course, the highest prevalence was in the Delta region, as we learned previously. Next, please. So what was the impact of COVID-19 on this national program? We had a number of National Committee for Viral Hepatitis units that were treating patients. We had 123 units and actually 50 more were in the national insurance hospitals. The total received treatment during the presidential initiative of the screening, the test and treat was around more than 1 million. The total enrolled patients for follow-up program for liver cirrhosis, 50,000, and total enrolled patients in the hepatitis B program around 9,000. So after COVID, what happened is only 24% of the centers were working regularly, full capacity, and the 72% of the centers were working 50% of their capacity, while 3.3% stopped working. Now we are also repurposing more and more of those centers, especially fever hospitals, instead of being triage hospitals, into isolation hospitals for COVID-19. All screening programs were disrupted for immigrants, prisoners, pregnant women, and also the school screening program was disrupted, so we stopped recruiting children, and those who are receiving treatment are getting the treatment every 3 months. They're getting the medications dispensed every 3 months. The hepatitis B program is facing some difficulties because of the lack of importation of the raw material. So there's shortage in medicine, and there is shortage also in research funding. And we had a lot of research studies that have stopped completely, and the clinical trials stopped recruitment of patients. Next, please. So if we look at the average number of healthcare workers per unit, the workforce dropped dramatically from over 2,500 to over 1,900 personnel. The number of shifts per day, most of the centers were working 2 shifts or 3 shifts. However, now most of the centers are working only 1 shift. The average shift per unit dropped from 1.29 to 0.99. Next slide, please. Similarly, the number of total visits dropped from more than 1,100 to 6,192 for patients before and after COVID-19. And the number of healthcare providers per patient ratio before the COVID was 1 to 5, now dropped to 1 to 3. Of course, they have full protection with full PPEs, and the total patients numbers dropped from over 4,000 to around 2,000. And currently, we're dispensing the medications every 3 months instead of monthly to decrease the number of visits per patients. Many other programs were disrupted. The screening for hepatocellular carcinoma is still ongoing, but at a longer duration of time, a longer distance. And of course, the outpatient clinics in many hospitals have stopped working, and therefore they are not receiving the regularly visiting patients with chronic liver disease. Thank you very much.
Thank you very much, Manal, and also Mohammed. I think an impressive COVID response, and it's great that it's been able to build on the expertise in the infrastructure from the hepatitis C response. So we're now going to move swiftly to Pakistan, which, as Egypt, has also a very high burden of hepatitis C, but also hepatitis B, where an excellent response has been established in Punjab, Pakistan. So we're going to hear from two leads in the Punjab response, Dr. Khalid Mahmood, who is currently the program manager for the Hepatitis and Infection Control Program in Punjab, Pakistan, with considerable experience in public health, and also Dr. Zahida Sawar, who has been working was the provincial program manager for the hepatitis control program and has held many senior posts in the Punjab Health Services. So over to first Dr. Khalid and then Dr. Saida. Thank you.
Thank you, Philippa. I am Dr. Khalid Mahmood, Program Manager, Hepatitis Control Program, Punjab. Next slide, please. You can see COVID-19 situation in Pakistan. 26th February 2020 was the day when first case reported, and we went for complete lockdown from 24th March to 9th May 2020. And after that, now we are observing smart lockdown, and that means small markets are open and private transport is allowed, no public transport is allowed, and the bigger malls and are closed at the moment. OPDs in all the teaching hospitals were closed, only emergency services were there, are the COVID focused services. OPDs in secondary level and primary level healthcare facilities remained open throughout this COVID situation, but some spaces and some staffs remained compromised there. So far as the situation is concerned, more than 34,000 COVID cases are confirmed, 737 deaths are there, over 8,800 recoveries are there. Next slide, please. You can see the trend from April 10th to the May 10th, there is 7 times increase in the COVID cases. The most affected age group is 20 years to 40 years, followed by 40 years to 60 years. 82% are males and 18% are females. Next slide, please. Hepatitis situation in Pakistan and Punjab and the response. In 2008, we had a survey that was zero survey in Pakistan level that showed that Punjab has 2.4% hepatitis B and 6.7% hepatitis C, meaning thereby 12 million people of the population of Pakistan, that was 172 million, had both the viruses. And when we come to 2018, we had a viremic survey in 2018 exclusively for Punjab that showed that hepatitis B has come down to 2.2%, but the hepatitis C has increased to 8.9%, meaning thereby that about 10 million people are viremic with hepatitis C out of 110 million population of Punjab in 36 districts of Punjab. The map is showing all that. We have 132 hepatitis clinics at district and sub-district levels, 17 clinics and teaching hospitals, and our PCR lab can do more than 2,000 tests per day. And averagely, we are screening and registering more than 500,000 people per year. We have developed a very robust EMR dashboard from August 2017 to this May 2020. We have registered more than 1.2 million people. We have screened more than 1.1 million people, and PCR detected for hepatitis B and C are more than 0.2 million people. And we have initiated on treatment 260,000 people, including privately diagnosed. We diagnosed in our PCR lab, and also privately diagnosed people are on treatment, initiated on treatment. SVI 12, we have done 11,498 people. Our cure rate comes 89% and relapse rate is 11%. That is the problem in inadequate treatment adherence at community level. I invite Dr. Zahida for the next slide. Thank you.
Thank you very much, Dr. Khalid. Hi, everybody. This slide shows you the summary of COVID impact on hepatitis response in Punjab province. And the table below shows performance of hepatitis clinic in 4 different phases. First row shows the performance of hepatitis clinic 2 weeks before lockdown. And then the second row indicates the performance 2 weeks immediately after introduction of lockdown. And then third phase, next 2 weeks after. And the fourth row actually reflects the performance of hepatitis clinic after holding a Zoom meeting by the provincial office to all MOs of the hepatitis clinic, wherein they shared the ranking of hepatitis clinic based on their performance with not only with the MOs of the hepatitis clinic, but also to the relevant medical superintendents. 5 major observations were made. There was a significant reduction in terms of new registration and screening of patients for hepatitis B and C, and there was reduction in initiation on treatment for both hepatitis B and C. And this reduction was significant, approximately 80% in first 2 weeks after introduction of lockdown. And in third row, you can see a bit improvement, but the significant improvement can be seen in the last row when feedback was shared with individual hepatitis clinic. 32 hepatitis clinics were found inactive during first phase and 117 were low performing, while PCR sample collection and transportation was halted in first phase, and later on it resumed on 28th of April. Next slide, please. This slide shows different key actions undertaken by the program to mitigate the impact, COVID impact on hepatitis response in terms of issuance of guidelines for clinics to work under COVID situation with disbursement of full course of medicine, and they also involved courier company for home delivery of medicines. 5 teams of provincial monitors were constituted in parallel to coordinate with the relevant hepatitis clinics, medical officers, and with relevant medical superintendents to sort out the issues and address challenges. At the same time, almost all MOs of the hepatitis clinic completed a WHO certificate course on infection prevention and control. And in addition, moreover, other guidelines on infection prevention, control, hospital waste management, use of PPEs were developed by the program provincial office, shared with all stakeholders, and virtual capacity building sessions were held. Next slide, please. Next, yes, this slide shows the concept of telehealth and teleliver. It is under consideration nowadays, and we aim to achieve 3 objectives through this concept. One is to raise health and hepatitis awareness of the general public, then to have patient consultation session to provide clinical advice through pool of technical people. And third one is the virtual capacity building of relevant healthcare providers in terms of MOs, paramedics, and data entry operators by pool of technical people. Next slide, please. This slide shows the hepatitis central PCR lab. This lab was actually engaged to perform COVID test at the moment, and first test was performed on 1st of April, and so far more than 30,000 tests have been performed. In addition to this lab, there are other 3 labs as well which are working to perform COVID test. But at the same time, hepatitis control program has developed a dedicated PC1 to strengthen this hepatitis PCR lab to perform in parallel hepatitis PCR tests for both B and C, because at the moment these services are suspended. So this PC1 has been prepared and submitted to the higher authorities. So these are the few interventions which have been undertaken by the provincial hepatitis control program, and we have shared with you all. This is all from my side. Thank you very much.
Thank you so much, Dr. Khalid, Dr. Zahida. Really excellent data to really inform the response, and I think showing an impact, but recovering, and some good examples of innovations with the sharing of the the platform for the molecular testing. We're moving on to the final presentation. Just for those of you still on the webcast, the live webcast will continue until all the presentations are complete. And we are going to finish with a quick 1 minute after the last presentation, a question to each of the countries, to 1 minute for the World Hepatitis Alliance, to Egypt, Pakistan, and to Malaysia. And for the, just so that you can be reflecting on your answers to the World Hepatitis Alliance, will be on the expanding role of the community going forward post-COVID, and to each of the countries to reflect on, in terms of the new normal and where we go next, what are some of the innovations, be it in community-based testing, building on experience with hepatitis C, be it sharing of molecular platforms, as well as telehealth, that you think are most important for the future. But I'd now like to move on to the final presentation, but certainly last is not least. Malaysia has established an excellent hepatitis program, very different profile to Pakistan and Egypt, more in higher risk populations. And Dr. Radzi Abu Hassan is a key lead in the response at the Ministry of Health, leading on the gastroenterology and hepatitis services, and is senior consultant physician and gastroenterologist also. So over to you, Dr. Radzi. Thank you.
Thank you, Philippa. Next slide, please. Well, the current situations in Malaysia, I must say, is very much under control at the moment. As you can see on the screen, that the number of people who recovered from the COVID-19 has improved tremendously. At almost 3/4 of those cases that have been notified so far, and the mortality is pretty low at about 1.6% at the moment. Next slide, please. Well, how do we bring all the situations under control? I must say that this is very much a well-coordinated and well-concerted effort by our National Security Council, which consists of a different ministry, and the key ministry who have been giving advice and also making the decisions in curbing the outbreak is mainly from the Ministry of Health. And I would like to point out that it is very, very important that to take the control of the COVID-19 in every single country, because the problems, especially the impact on the service delivery, is very much depend on how do we control our COVID-19. I also like to acknowledge our Director General of Health in Malaysia, who will be the key person behind the control for the COVID-19 in Malaysia. He and his team has been navigating the crisis very well, to the certain extent that the number of cases of COVID-19 in Malaysia has come down to double digit, and probably I think soon it will be a single digit. Next slide, please. As mentioned by Philippa, that hepatitis C in Malaysia is probably slightly different. We are very fortunate in the sense that the magnitude of the problem is not as huge as in Egypt and also Pakistan. The prevalence of hepatitis, I think from the latest survey, I think we're probably looking at about 1%, probably less than that. But even that, I think it still poses an important public health issue. Next slide, please. So this is among the strategy, a multi-pronged strategy to combat hepatitis C in Malaysia, which include the central coordinations, the policy tool, which I must say had the compulsory licensing, which has been enforced in Malaysia in order to suit the limitations that we have at that point of time. But one of the strategy which I would like to highlight here would be the decentralization. This is the key driving force strategy to combat hepatitis C. Having said that, people or the healthcare workers who are involved in the implementations of the decentralizations of the viral hepatitis C are also some majority of them are also frontliners. So hence the impact of the COVID-19 has significantly also have some impact on the hepatitis C decentralization in Malaysia. Next slide, please. Okay, these are the, at least down here, what are the some of the impact that we have so far. It's nothing much different from the rest of the speaker that has been mentioned earlier. The follow-up visit has been postponed to a certain extent. Treatment has slowed down a lot, especially in the red zone area. Accessibility to the healthcare is restricted, particularly to among the people who inject drug. And the laboratory turnaround time is also has been lengthened significantly. And to a certain extent, the trial or the clinical trial recruitment is also quite heavily affected as well. Next slide, please. So what are the measures that have taken so far to mitigate the impact of the COVID-19? I would like to highlight some of the important measures that have been done by Malaysia so far. One of the measures is the drug delivery to the patients. So we have, or the government of Malaysia has provided what we call is the complementary medicine delivery, i.e. it's a courier service, in fact, to all the patients who, especially those who are unable to access to the hospital. So this is something which is is a significant effort by the government of Malaysia in terms of providing, or in terms of ensuring that there is continuity of the drugs. And also we encourage and also we enhance the use of what we call this the drive-through in getting the medicines to the pharmacy. This is already an existing what we call the service available even before the COVID, but I think we encourage our patients to use this facility, the drive-through to the hospital. And we also engage our civil society, especially among the PWID patients, to help or to facilitate for them to get the access to the care. At the same time, anticipating about the some of the what we call this expiring drug towards the end of the year, so some of the DEA has been redistributed from the red zone to the green zone, so that the people or the healthcare provider at the green zone can start to initiate or can increase the number of patients that can be started with the DEA. Like in other countries, for the patients who are emergency and also semi-emergency cases, there always still the facilities and also space for them available at the hospital. So this is not affected at all. So we ensure that there's a continuity and also the accessibility for those emergency, including the upper GIT bleed, as well as the ascites or any liver complication. And I can also see that we are moving more and more towards telemedicine, as been mentioned also by the other previous speaker. So with that, I conclude my talk, my short brief overview or experience of the impact of COVID-19 on the service delivery, particularly on hepatitis C. Thank you very much.
Thank you so much, Dr. Radzi. And as I mentioned, we are going to just hear from each of the presenters with their key take-home messages before Thomas Berg closes the meeting. So I'd like to turn first to Kerry James. Again, very short, brief take-home messages, Kerry, particularly on the role of the community. So a few remarks from you, please.
Absolutely. Well, I think we've seen that, you know, the groups that are, many of the groups that are disproportionately affected by COVID-19 are also the groups that are disproportionately affected by viral hepatitis. So there's a real role for hepatitis community, civil society organizations to play a key role when it comes to, you know, rolling out large screening programs and hopefully in the very near future, large vaccination programs. But on the other side of that coin, it also means that if there are large COVID programs going on in these communities, you know, it is an absolutely might be once in a lifetime opportunity to also screen for hepatitis and to get those people on treatment. So I think the role of community on both sides of that coin is absolutely key. And as we leave or emerge from the COVID crisis and we look at how health systems will be evolving, not only with the new normal that we'll have, but also in the age of universal health coverage, it's vitally important that hepatitis community organizations place themselves at the center of that progression and of that development, and that hepatitis is considered an absolutely vital part of UHC programs. Thank you.
Many thanks, Kerry. Moving now to Egypt and starting with Dr. Hassani, just key take-home messages. Clearly, Egypt was on track and had ambitious plans for elimination of hepatitis C. How much of a setback is COVID? And what does the future hold? Where now?
Now Egypt is moving towards a tolerance plan. It looks like an exit plan to maintain the healthcare facilities, our screening programs, the access to treatment, the management of and follow-up of the patients with liver cirrhosis. And I think that every country should do that, because we need to make that tolerance plan finally improve the healthcare system, and to avoid the long-term impact of the shortage of healthcare system and healthcare services for such important group of patients. We do not need to all of us to go for facing COVID. And finally, we left a large number of people with different comorbidities and different diseases facing their diseases alone. We should gather our efforts. We should augment different plans and different models, adopting them, like telemedicine, like delivery of medications, to strengthen that plan and to support that health services for either for the long or the short-term plans. Thank you very much.
Thank you so much. And to Manal to add some comments, and particularly perhaps flagging the issue of children and adolescents and the research agenda and the way forward.
Yeah, I think as Mohammed mentioned, this is an opportunity rather than anything to strengthen the healthcare system and strengthen the lab diagnostic capacity and human resources training, as well as infection control, because that used to be one of our issues leading to new infections on regular basis. As far as children are concerned, the vaccination programs currently for Hep B are not disrupted, apart from some mothers who do not like to go to vaccinate their children because they are concerned about infections, and some of them are delaying the booster doses for vaccination. But for the school program, that's going to be a challenge, because we used to go on schools on site to screen children. Unless the schools they go back to the regular, it's going to be very hard to go back to screening children. For research, I think that's something for the international community to start discussing. We had one of our research studies with the University College in London. The funding was stopped because it was repositioned and repurposed for COVID-19. I think we need to think about a sort of mechanisms to merge or to think of how to continue doing our research studies while there is COVID-19, and maybe talk a little bit about the impact of COVID on liver disease and on patients with viral hepatitis. That might increase the funding and improve the funding.
Thank you, Manal, and thank you, Mohammed. And now to Pakistan, and I think we had ambitious plans for you with the micro-elimination strategy in Punjab, for which you've made excellent progress. Where do you see the future there? And also just flagging some of the opportunities that have been highlighted by the other speakers. Out of adversity comes opportunities. Comments from Punjab.
Yes, thank you, Philippa. As you have already mentioned, we were running our project of micro-elimination in district Nankana Sahib, and we gone through the pre-testing phase of one union council successfully. And all the colleagues, when they came over to Lahore on 3rd, 4th, and 5th of December, they witnessed that union council and the community, participation over there. We have that micro-elimination scale-up plan in our mind. We have a number of union councils in the pipeline. We had made arrangements for 32,000 population of 2 union councils of Nankana Sahib. We had selected 1 union council of district Sialkot, another high prevalent district, and 1 union council of district Multan, one of the hotspots we have identified. And we went for the scale up of micro-elimination into district Toba Tek Singh, and our governor, Chaudhry Sarwar, was very much interested, and we joined hand with an NGO in the Pakistan Liver Care Organization in Toba Tek Singh. And we also signed a memorandum of understanding with Sarwar Foundation, an NGO working for hepatitis in Punjab. The work was in pipeline, but all that due to COVID, restriction, and that we had to stop those activities. But we are very much keen, as the sooner the situation settles down, even if it does not settle down completely, but we learn to live with COVID, and we will inshallah start our activities accordingly. And we have the logistics, we have the medicines, we have the tests, and our lab is going to be strengthened day by day. So no doubt, it's at the moment it is stuck up with the COVID testing, because our most 6,800 machine is doing more than 1,100 samples of COVID testing nowadays. And our 4 units of Abbott were supposed to be doing our hepatitis C PCR are occupied for extractions as auto extractors for the COVID testing. But we have the scale-up plan, and we are going to develop our lab services as well. We are taking this threat as an opportunity nowadays. And the tele-liver project is at the verge of launching, and we have started groundwork for that. And inshallah, we will manage our hepatitis clinics through our tele-liver project, our tele-liver capacity building, our tele-liver community engagement as well. We are also working on the RCCE, risk communication.
Thank you. I think we just need to move on to the last speaker. Thank you so much. I think we need to just move on for the last comments from, because we are running over. Thank you. Over to Dr. Radzi for final remarks from Malaysia on this same theme. Thank you.
Well, I think the 2 points perhaps I would like to highlight here. Number one, well, in the crisis of COVID at the moment, it is very crucial that every government or every country must try their best to bring the situation under control, because that will determine the impact on the other services, including the hepatitis or hepatology services. So once we bring it, the earlier we bring it to normal, I think then the service probably can be restored as much as possible. The second message, the second point which I would like to highlight will be that we have to come to the term, because we know that COVID-19 is going to stay for quite some time. So we have to live with it. So we have to formulate what we call this the new normal, or actually near normal, so that we can continue the service of our hepatitis and also for hepatology as a whole. Yeah, that's my main message.
Great. Well, thank you so much. And thank you all on the webcast for bearing with us to allow us to complete the presentations and these final remarks. And I think what we've heard is some very positive messages of opportunities coming out of the COVID response to expand the community role, the opportunities for telehealth, the sharing of technologies and lab platforms, and hopefully to restart the elimination plans in Punjab and elsewhere in the near future. I'm going to hand back to Thomas for the closing remarks. Thank you.
Yeah, Philip, thank you so much, and fully agree. I think what we probably can learn from this pandemic is how effectively we can control viral infections if everyone works together, if we have good science, really a global effort to this. And this can also teach us something to get rid of the hepatitis viruses. These are infectious disease. We know that they are well controlled, they are preventable, they are treatable. So what do you think? Will this be a window of opportunity also to foster our elimination strategies and to reach the WHO goals?
Well, I think that's a good question mark for us to finish on to lead into the next webinar. But yes, I think it is an inspiration to see all the innovations that are coming out of the COVID response. And I think it's how well we can embed them in the new normal that as we move on.
Okay, so to the audience, to all the listeners, thanks very much. And I would especially like to thank you, Philippa, also for bringing this idea up and really starting this initiative together with EASL. All the speakers, a great thank you. It was a great experience. And I would like also to thank the people behind the scenes. And these are the people from the technical part, the Connect2 CME, with a scientific leader is Shamil Bashar and his team. So thanks a lot. And a special thanks really to Munia Haddad Masson. He's head of education at the EASL office. A great thank you. Wish you a good day. Stay safe, stay healthy and motivated. Thanks to all of you and see you soon, hopefully. Bye-bye.
Thank you.